Okay, so welcome everybody to our ATS Critical Care COVID webinar. We're excited to have everybody on today. My name is Sushma Cribbs, and I'm part of the working group that has been sharing these webinars for you over the last few weeks. I'm going to start by just sharing a few slides for you as an introduction, and then we'll get started on the topic. So I just want to introduce you to our COVID-19 Critical Care Training Forum. Again, we're having these every Tuesday from 8 to 9 Eastern Standard Time for those of you that have been tuning in the last several weeks. Just to kind of run through some of the ones we have done so far, you can watch these or re-watch them on our ATS website. So the first one we had in April was treatment of hypoxemia and COVID. Our second one included updates on clinical presentation, challenges, and workflow from hard-hit areas. The week after, we had challenges with sedation in critically ill patients with COVID-19. And then we did care of the COVID-19 patient from home to the ICU. And last week, we did mechanical ventilation in COVID, adjusting vent settings and consideration of tracheostomy. And next week, we have a topic called Healing After COVID-19, which will have a case presentation and several very famous discussants to talk about what we do after COVID-19. So please stay tuned for that and register for it. It will be next Tuesday from 8 to 9 o'clock Eastern Standard Time. This is the scan, you can QR code they can scan to get all our training forum archived videos. And please give us feedback. Please take the survey if you can. It really helps us figure out what kind of topics you want to hear about. We're doing this to serve you and to reach as many people as possible. So please take the survey and give us feedback on the topic now and any other new ideas that you'd like us to talk about. This is our training forum leadership, all of whom have worked really hard to bring these talks to you, especially our ATS staff that have been working tirelessly to really bring these to your home, wherever you are. So thank you to all the chairs, the working group, our internal resident team, and the ATS staff. Okay, so I don't want to talk too long. I want to bring us to our topic for today, which is COVID-19 challenges, palliative care, communication, and end of life in a pandemic. Again, my name is Sushma Cribbs. I'll be moderating this. I'm going to turn it over to Nicole Herbst, who will be starting with the case presentation and will be our speaker for this presentation. We also have a fabulous panel of discussants, which Nicole will introduce. And I just want to thank them all in advance for coming and doing this with us today. So Nicole, you want to share your screen and get started?
Sure. Okay. Can you see that, Sushma? Okay, great. All right. So first, just introduce myself. My name is Nicole Herbst. I'm currently a first-year pulmonary critical care fellow at Emory. And then I just wanted to briefly go through our incredible discussants who are joining us today. First, we have Dr. Randy Curtis, who is a professor of the Division of Pulmonary Critical Care and Sleep Medicine at University of Washington, as well as the director of their Cambia Palliative Care Center. We have our own Dr. Quest from Emory, who is a professor in the Department of Emergency Medicine, as well as Family and Preventive Medicine. And she wears many hats, including the director of our Emory Palliative Care Center here. And then lastly, we have Dr. Dina Khateeb, who completed her pulmonary and critical care fellowship at Jefferson and is currently a hospice and palliative care medicine fellow at Mount Sinai. So they'll be chipping in along the way with their thoughts and expertise. So this is a topic that I'm really excited to talk about today. While I think, palliative care and end-of-life care in the ICU is important all the time, it's definitely something that struck a nerve and had an increasing burden. I think for the mainstream media and society at large, as you can see, but also for providers as well. So some objectives for tonight. First, I'm going to go briefly through a case presentation, and then we're just going to go through a series of challenges that we've encountered and others have in providing palliative care and end-of-life care to critically ill patients with COVID, as well as identify some strategies to address these challenges and discuss the available resources out there. So I'm just going to jump right in to the case. This is a gentleman I took care of in our COVID ICU a few months ago. He's an 83-year-old gentleman. He has a history of hypertension and diabetes, is otherwise independent at home, although he did have a prolonged hospitalization about 1 year ago for gallstone pancreatitis, where he was in the ICU at that time. He's coming in with 1 week of shortness of breath, fevers, and fatigue. On arrival to the emergency department, he's in mild respiratory distress and requires 5 liters of oxygen, and his rapid COVID test comes back positive. Unfortunately, very shortly after his arrival to the emergency department, he becomes more altered. He has increasing oxygen requirements. He's on maximum high flow nasal cannula. He's unable to make decisions at this time, given that he's altered, but on chart review, it's noted that after his prolonged hospital stay last year, during an outpatient visit with his primary care doctor, the decision had been made to be DNR-DNI. The team calls his wife, who unfortunately, due to visitor restrictions, is unable to come into the emergency department, and as you may imagine, was very distressed at the situation and not being able to be there with her loved one. And after this conversation over the phone, decides to reverse her husband's DNR-DNI status and wants the team to proceed with intubation. So he's intubated and transferred to our ICU. He has a prolonged ICU course, which we see in many of our patients with COVID. He has refractory hypoxemia requiring proning and paralytics multiple times. He has renal failure requiring CRRT with no evidence of any renal recovery over several weeks. Refractory shock with difficulty, taking off his pressors. He has a ventilator-associated pneumonia, which is treated, as well as a DVT and likely PE, although not confirmed because we weren't able to get a scan. Just a little bit about our communication strategy that was going on at this time. We had automatic palliative care team involvement for all of our patients in the ICU, which I can't stress enough how incredibly helpful that was, because in addition to the palliative care team reaching out to the family every day, the ICU team was as well, and those frequent updates really helped in the setting of her not being able to be in the hospital. We also had the opportunity to use an iPad daily, either the nurse or the chaplain, whoever had time, so that his wife could see him every day. But as you might imagine, there's just a lot of family anxiety around the unknowns of COVID, potential therapies, all the changing options in the press. And so communication was something that we all found challenging. Unfortunately, 2 weeks into his ICU stay, he developed spongemia and worsening shock. This posed many challenges given he was requiring multiple pressors as well as CRT still, and options for line holidays were limited. After multiple discussions with his family, the decision was ultimately made for us to focus on comfort. And per our hospital policy for patients at the end of life with comfort measures, we are able to bring in 2 family members inappropriate PPE for his passing. And thankfully, we were able to give them enough time to do that. He remained on the ventilator in a spontaneous breathing mode in order for us to try to prevent an aerosolizing procedure of extubation and try to protect his family members from that exposure as well. Okay, so there's a lot to unpack here, and I'm sure we all have stories and patients that are very similar to this, unfortunately. As we've seen, patients with COVID can have a very prolonged critical illness with multiple complications, and the difficulties communicating and dealing with the end of life sort of overlie all of that. So I wanted to highlight just a couple of the challenges and go through some some potential ways that we can address them. I think one of our biggest challenges is communication in general. And this is sort of across the board. The way that we communicate with patients and families has completely changed in the time of COVID, both for patients with COVID and without. Even when we can communicate with a patient who's awake and alert, we're in full PPE and having difficult conversations about hard decisions is very challenging. Communication with patients and families is also very difficult. Loved ones can't be at the bedside having those conversations with patients. And then we're also having these difficult conversations over the phone. And as you can see, people have gotten creative with technology or just simple standing on the sidewalk and waving when they can. And something that I have really seen in communicating with these patients is the isolation. Not only are you communicating with patients, loved ones over the phone, but often their loved ones themselves are isolated or in quarantine and, and very scared, honestly. So, that I think addressing that anxiety and that fear, I've found to be really important when trying to have these difficult conversations over the phone. It's just, usually in the ICU, we have the luxury of having families at the bedside frequently, and without that, communication is very challenging. And so this brings us to how we have our advanced care planning discussions with patients and with families. As always, our aim is to provide goal concordant care, and to do that, elicit goals early, and that's something that we're used to doing prior to COVID. But now in the time of COVID, in addition to, being concerned that if we're not providing care that's concordant with goals, we're obviously always worried about, first and foremost, harming the patient, but now there are other considerations that we have as well, including putting healthcare workers at risk, as well as resource utilization. As we know, codes can be very risky. There's a lot of staff and patients in the room, a lot of use of PPE, and that shouldn't be the reason not to code somebody, obviously, but we want to make sure that we're providing care that aligns with patient goals, especially now. And I did just want to mention that a lot of us are still having telehealth visits with our patients with chronic pulmonary disease, and these conversations are a really great time to start to bring up these conversations if we haven't already. So that way people are prepared and have had these conversations if unfortunately they do end up in the hospital. I wanted to briefly touch on a paper recently that one of our discussants, Dr. Curtis, as well as others, published discussing advanced care planning. And I'll briefly go through this, but I'll maybe let him speak to this a little more. But brought up a very interesting concept of informed assent. And I'll go through exactly what that is. It's really a step further than making a recommendation in terms of CPR and life-sustaining therapies. If the patient is determined to be appropriate for this, really the steps are briefly describing what CPR is, and then after you've elicited goals, really describing what you think the chances are of CPR reaching those goals. This framework is really nice in that it lays out sample phrases that you might use. For example, given what you've told me about your mother and her goals, CPR will not help reach her goals. So you elicit the patient's goals, you describe how CPR may or may not reach those goals, and then this is where, taking it one step further than that recommendation, whereas you present a definitive assent statement, essentially saying, since CPR won't help you or your loved one reach those goals, we do not provide it. And then after that, really gauging family response and understanding, with the goal really being using our medical expertise and understanding of the situation to help families make decisions so that we can provide care that's concordant with goals. This also helps to decrease burden on family members who are having a really hard time making these decisions, especially when they can't be there at the bedside. All right, so I'm going to pause for a moment here and pass it over to Dr. Cribbs.
Thanks, Nicole. I'm going to stop your sharing for a moment so that we can see discussants as well. So thank you so much for that introduction. I think we have all been in that position and seen your patient multiple times. And I think it's just a really important place to discuss and to start with our discussants. So we did have a few questions in the chat, but before we got to that, since you mentioned Dr. Curtis's article, I was wondering if we could stop and maybe talk about that for a little bit and sort of this idea of informed assent. So Dr. Curtis, Dina, and Dr. Quest, what has been sort of the practice or recommendations that you've had when these patients are coming in and you're having these discussions over the phone? Is an automatic palliative care consult, and how do you coordinate that with the ICU teams? Maybe you can comment on that and your algorithm, Dr. Curtis, as well.
Yeah, I mean, I can start by saying that in terms of how we coordinate between the palliative care team and the ICU team, we haven't been having an automatic consult for all COVID-19 patients in the ICU, but what we have done is every weekday, the palliative care team comes to the ICU around 11:30, rounds are over, and we actually run our entire list with them. And during that time, we've had a census in our ICU, COVID ICU, of 12 to 15 quite frequently when I was on most recently. And of those, we'd probably have them get involved and see 5 or 6, be aware of another 5 or 6. And I thought that was a nice way to use their resources, their time, as efficiently as possible. And alluding to one of the questions in the chat box, it's really important that if multiple teams are calling the family, they're on the same page and saying the same thing. There's nothing more distressing to families than hearing different things from different people. So I think that's a really key piece, is that's a chance to say, who's going to call the family? If we're both going to call the family, what are we saying? And making sure that it's coordinated. But I have found that the palliative care team was really helpful to the ICU team for this family communication piece. The families can't be there, they can't be at the bedside, and so having a call, the ICU team called the family every day, but that's one phone call and it might be 10 minutes, and that's so different than normal operating procedures. So having the nurse call each shift and having the palliative care team call, I think that families have really appreciated that level of communication.
So I find also that, and Nicole, you alluded to this earlier, the conversation on the phone is just so hard. You can't read people's faces and you can't utilize your emotional intelligence as you're having these discussions with people. And it's been incredibly difficult for me trying to do this over the phone. And Nicole, you alluded to technology a little bit. What kind of technology or other communication best practices have you all used or tried or recommended to help with that?
So I'd love to jump in on this one. So one of the things that, so we've got 5 hospitals in our system. So each of our palliative care teams, there are 25 attendings across, these different hospitals and APPs and other team members. And so we've tailored it. Each COVID ICU we've leaned in to and been proactive, and the strategy is different for each one depending on what they feel like they need. So one of the things that we did universally, we deployed something like I think 28 iPads in pairs. So to be able to do iPad family meetings, which is different than visitation. So you can have visitation where someone's just visiting their family member, but the ability to bring the entire care team together along with the patient family, along with the patient, was something that we perfected fairly early on, and in the sense of using Zoom and bringing people from all over to be able to participate in decision making. So that was something that we have done, and we've gotten extremely good feedback from families, and we surveyed families and providers around feasibility of that. So I think that if you take it one step further from check-ins, so check-ins I think are one thing, but I think when you're really talking about complex medical decision-making, that's a family meeting, and the ability to have the critical care team, the palliative care team, the subspecialist, and the family from local and far all there, and the patient in the room. We've been incredibly successful at that, and so that's something that we've done, the sort of family meeting where you're bringing the care teams together with the patient and family.
I'll just speak to some of our experiences, and I think what Dr. Quest and Dr. Curtis shared, we experienced also. We didn't have automatic palliative care consultations. We had embedded clinicians within each of our COVID ICUs, and, due to sort of the sheer numbers, certainly not everyone received palliative care intervention, but we would round with the social workers who were working from home, our chaplains who were checking in with patients' families, in addition to the ICU teams to sort of triage or flag patients or families that we felt would benefit most from interactions with us. And then, to speak to the communication challenges, I think the added level of challenge, even with technology, is that, there's lots of disparities in technologic capacity. Several, elderly patients, whose surrogate decision makers are also elderly themselves, and have limited capacity to access technology via Zoom or iPad. And so, a lot of our conversations were also held over, just conference telephone interactions. And again, that speaks to the challenge of, being able to read nonverbal cues and sort of reading the room, which is also really important in having these difficult conversations.
Yeah, absolutely. I find that the most challenging. There was one of the questions in the chat was about discussing dialysis in a patient like this. Any thoughts about that for Nicole's initial case presentation? Is that a discussion that you would advocate having earlier, later? At what point, do you have that as part of your DNR discussion, I guess?
I would advocate for thinking about intensity of care and the goals of care, but not parsing out each individual treatment. So to me, having a discussion about, the ventilator versus dialysis versus, other kinds of forms of intensive care doesn't make necessarily as much sense. I think it'd be different if we thought the chances of if the patient going on dialysis, the chances were high that they would be permanently on dialysis. For example, the patient who was quite marginal at baseline, in terms of his renal function, but in a patient who seems likely to have a good chance of coming off dialysis, it seems a little less relevant up front to me than the big picture intensity of care that we're providing.
So along those lines, Dr. Curtis, and for anyone to jump in, you know, with COVID, we're seeing, you know, all ages, all patients, people who were not sick are now sick suddenly. It's just a different population than what many people are used to seeing in the ICU. And so I think it's become very difficult, at least for me personally, I don't know how the audience feels, just having these discussions when things happen so suddenly and everyone's watching the news and waiting for a miracle. And, you know, so any thoughts on how to kind of handle some of that communication and how to discuss that early on or even later? Do we hold off on some of those traditional conversations we've had always? Because it seems like, you know, this is a situation where everyone just got hit by a car. They were fine one day and then they weren't, you know, and I think that's a different level for a lot of families and where they are. They haven't been chronically ill.
Yeah, I mean, I would say it's very important to consider the underlying health and age of the patient. I mean, early on in the pandemic, a lot of the patients we were seeing were older, over 70, with comorbidities, and coming in and relatively early on having multiple organ dysfunction. To me, that's a very different scenario than the 55-year-old who may have had some hypertension but was otherwise fine.
Right.
So in the former patient, that's the patient I'm more likely to think about using informed assent to move towards DNR, potentially even DNI. I mean, I wonder whether Nicole's case, whether there might have been a conversation to be had saying, you know, based on what he has said in the past, and given, you know, his age and comorbidities, you know, intubation doesn't seem in line with what he would want. And if it's not what patients want, it's not something we usually do. Sometimes that can really help families make a decision that they would want to make, but that they find personally is really hard for them to make. That family members will often choose more intensive care than patients would choose for themselves, in part because they're in that awkward, difficult position of being a surrogate decision maker. You know, there are exceptions to that. My 16-year-old daughter has told me many times that she can't wait to withdraw life support on me, but I think for a lot of patients, you know, their families are going to be more conservative in that way.
Sure. So along those lines, we did have a question in the chat about someone was asking that they were under the impression that surrogate decision makers have to make medical decisions that are consistent with the patient's prior stated wishes. And so in this situation, are the family members acting as appropriate surrogate decision makers if they change the patient's recently documented wishes?
One of the things I think it's a challenge in looking at this, we had exactly this situation where one of my providers tried this approach, and the family pushed back pretty aggressively and said, "Are you asking us or are you telling us?" They were very clear. They got it. They got that this was, you know, which direction? I mean, are you giving me a choice or are you saying that you're not going to do this? And so they were very clear, and it was this was actually not in the patient had wanted life-sustaining therapies before. Multiple people didn't think it would be in the patient's best interest, so it's a little bit of a twist there. And so I think you have to be really careful in this being a very strong recommendation. But when families push back, or if they push back, I think you have to understand based on your state laws, based on your own hospital policies, whatever that process is, if there is conflict, I think you should be ready for that in advance and anticipate that there could be a conflict there, understanding that we can always resolve those conflicts. But I think to expect that, you know, we would have that approach and not have conflict, I think that you would expect that that's a possibility. And so in this case, in using that approach, I will tell you that we did take more into consideration. She was COVID. She was 96 years old, going to the ICU, and she survived and left the hospital. They really insisted that this kind of care be provided because they said that that was sort of her wish, and that despite the fact that we didn't recommend that. So I think it can be complicated, but I think you can only practice medicine prospectively. You cannot practice medicine retrospectively. And so making strong clinical recommendations is imperative in these situations based on what we know. But I think you will have to potentially, the idea that surrogates might not do what a patient wants, depending on your state law, that can be a little bit tricky because every state doesn't enforce that to the same degree. In our experience, in the state of Georgia, it's pretty squishy.
Yeah, that's great advice, Tammie. And you actually addressed a recent question that just came up about state laws being different in this situation. So it seems like they are, especially regarding reversal of decisions made by surrogates. Is it different state by state and hospital by hospital has been your experience with that, or?
State by state for sure. Hospital policy typically, in my experience, it's really working with hospital legal to determine how comfortable they feel typically around pushing against surrogates. In every state in the union, there is a way for us to challenge surrogates when we believe they're not acting in a patient's best interest. We should always know that that's always a possibility. It just depends on if your hospital will meet you in that challenge. And so I think that it's just something to consider and expect. But I think our obligation is exactly what Randy is talking about, that we do need to, in the strongest terms, be able to recommend treatments in the best interest of patients, knowing what their wishes are when they are known.
Absolutely. Well, Nicole.
I'll just add one point.
Absolutely. Please.
Yeah, I totally agree with Tammie. I think it's very important to know the state laws and the local policy at the hospital. I do think that informed assent, as we've conceptualized it, is different than a strong recommendation. Mm-hmm. The idea behind informed assent is that there are some family members who can't take responsibility for a decision, but are very happy to let you take responsibility for that decision. And the idea behind informed assent is to relieve those family members of the burden of making a decision that in their heart of hearts they know is the right decision. They just can't be brought to be the ones be responsible for it. And I also think Tammie's point is really important, that if you're going to use informed assent or a strong recommendation, you will find family members who say, no, wait. I don't agree with that. I'm not going to let you make that decision, or I'm not going to follow that recommendation. And then you have to have a way of addressing that. That is, that often involves negotiation. And in my experience, a lot of times the point then is to work on building trust, to step back from the decision if you can, and to focus instead on building trust with that family.
Is it different in the time of COVID? Is this concept different in the sense that you now have, as one of the folks mentioned in the chat room, that the mortality is super high with renal failure, with respiratory failure, multi-organ failure in this illness in elderly patients, and you're putting a team at risk when you say we're going to do something that we know isn't going to change an outcome. So is this concept different in COVID than it is for our regular ICU patients?
I would argue that the ethics are not different, that the principles at stake here and the way we want to conduct our communication is not fundamentally different. But I also do think that, so in my hospital, we can write a unilateral DNR order over the objections of a family member. In my career, I have never done that pre-COVID. I have done that since COVID because there have been situations where patients are on maximal support, 100% high PEEP, high pressors, getting worse. This is the family that can't agree with even informed assent for not coding a patient. And we have said, we're not going to code this patient. We're not going to do ACLS and cardio and CPR. We have a policy that allows us to do that. So I do think that there are some differences for the reasons that you mentioned, but that in general, I think the ethics and the approach should be the same.
So along those lines, just one last question, and then we'll get back to Nicole, is, and this came in the chat as well, do you have ethics committees that are involved in your institution to help you make these decisions and to support decision-making with the palliative care team and the ICU team when things like this happen? Or to help guide the decision-making?
Yeah, we have a robust mechanism for that, I think, and I think the more minds that you can bring to the table, sometimes I think we're worried in the position of palliative care and working with my critical care colleagues. I know that complexity, you're dealing with a lot of complexity, calling in more consultants, calling in more people sometimes can feel unwieldy. I think in the time of COVID in particular, having more minds to be creative about how we're going to approach difficult patient care issues, I think is really good. And we've seen that be helpful in our cases, pre and post COVID. But I think post COVID in particular, and in particular when the conflict is escalating, because that's not our goal, to have conflict escalate.
Absolutely. Okay, well, we'll pause on the discussion for now, so let Nicole get back to her case, and then we'll come back.
Okay, so I wanted to touch a little bit on the high morbidity and mortality in these patients. We've touched on a lot of this already, but as we know, these patients can decompensate rapidly and go from being relatively okay to needing life support very quickly. And so the earlier these conversations can be had, the better. And as we know, there's risk of more severe disease in older patients with comorbidities, which is not a concept that's new to us in critical care, but I think another aspect that makes these conversations hard on our part as the providers is the uncertainty with COVID in general. And, we're starting to learn more about outcomes and how sick these patients get and who does well and who doesn't. But I think that uncertainty really flavors our conversations with families as well, and maybe the strategies that we normally use to have these conversations we find a little bit more difficult because of our uncertainty. But I think it is important, like we've talked about, to trust our clinical judgment, and no matter what has gotten a patient to multi-system organ failure requiring multiple forms of life support, we have a sense as clinicians what therapies are not going to change the outcome or get a patient to their goals. And so I think being honest about that fact that there is some uncertainty, but then also recognizing that, we do have our clinical judgment and experience, and that's definitely meaningful. And just to briefly touch on this morbidity and mortality, the estimates of mortality vary widely. This is some data from the CDC showing that about 25% of patients who end up in the ICU unfortunately die. And this is around the same mortality as we see in patients with severe ARDS and respiratory failure from other causes. And this brings me to my next point, which is resource utilization, which is a big topic, and we've talked about a little bit because it sort of touches all other challenges as well. A big one being PPE, which is varying from hospital to hospital, but obviously we're always trying to limit the number of providers going into a room, the amount of PPE that's used. The resources of our healthcare workers, which I think is one of the most important things, how do we utilize our palliative care teams, our chaplains, our social workers effectively, and implement them in the best way to help with our communication and the care of these patients. Prolonged recovery and rehabilitation is a big one, and something we already see in our ICU patients, and we've touched on a few times already, that these patients have very prolonged ICU stays, and that comes along with all of the complications down the road, both mental and physical health, and this is something that our healthcare system is going to need to address moving forward. And then, we've talked about resources for communication, but all of those things, technology to aid in communication, cost money and resources, and how do we allocate that? In addition to iPads, our ICUs have utilized baby monitors. They're a little bit more low tech, but help with communication from providers outside of the room to inside of the room, and then sometimes allows us to set up a phone where family members can just speak into the baby monitor outside of the room. It means that we're limiting the PPE because somebody doesn't need to go into the room, and then family members can talk on the phone into the baby monitor for an hour if they'd like, and we found that some family members found that helpful. So we'll pause here again for just some more discussion and comments on resource utilization in general, because I know this is something that depending on institution, people deal with in very different ways, and the constraints depending on the patient load are very different. But I'll pass it on to Sushma.
No, thanks, Nicole. So, I think we talked a little bit about the morbidity and mortality and resource utilization. I'm curious to hear from the group about how you factored that in at your hospitals regarding resource utilization. Dina, in New York, if you can, I'm sure you had to think about this pretty regularly on. Did you have a committee that helped with that or discussed that, and how did you think about the best way to utilize all your resources there?
Yeah, I think that was a very important topic of discussion. There were definitely committees discussing resource allocation across the healthcare system. We have several different hospitals, and each hospital, I think, was experiencing their own challenges in resource utilization and limiting that. I think with regards to our, specialty within the palliative care department, a lot of our work was done via telecommunication, and really without needing to use PPE unnecessarily. We do have a palliative care unit, and so we took care of several COVID patients in our palliative care unit. And again, there was a lot of careful thought placed into how to best use our PPE and sort of limiting extraneous use of that in our palliative care unit. So there was a lot of careful thought.
Did you have to have discussions about limiting ventilators in patients and those kinds of discussions as well, or?
No, I think thankfully, with the actions of social distancing, we were really sort of able to avoid that crisis situation. And so we were operating under sort of contingency strategies at that, at the peak and surge of what we saw here.
I think this is a really important issue, and one of the things that we were one of the first cities to get hit in the U.S., and we worried a lot about hitting crisis standards of care, and we never did. We didn't get even nearly as close as New York or some other places in the country. And yet the crisis standards mentality creeped into clinicians' thinking, and you could see them having thoughts about prognostication and withholding resources that they would have in a crisis standards of care, but that we really shouldn't be having if we're not there. And we actually have a piece coming out in the Journal of Pain and Symptom Management any day now that really highlights this and provides a prognostication tool for COVID-19 and really asks people to look at their biases, because it's really easy to slip into that way of thinking when we're not there. You know, somebody mentioned the 80% chance of mortality. That's high. And yet we all know families and patients who would say 20%, sure, I'd go through the ICU for that. And so I think we have to make sure we're really careful and thoughtful about our thinking process.
Yeah, I'm really thankful you brought up that consideration of our biases. And, you know, we've spoken a lot about age. You know, I think there are different phenotypes of a 75-year-old with hypertension and diabetes. And I think aside from age, we just really need to be careful and also considering frailty and sort of who the patient is prior to this hospitalization and factoring that in with regards to prognosis and not really sort of focusing so much on just age as a number.
One of the things that we've done in thinking about resource allocation and sort of developing those guidelines as they're underway, one of the things that I was involved in recently was training all of the potential members who might be in a position of making decision and doing unconscious bias training, and having all of them undergo the implicit association test. And we did it on 3 areas: weight, disability, and race, because we believe that those are areas that people make judgments about patients very quickly that may not be evidence-based, and are clearly, you know, because it's unconscious, right? We wouldn't expect that people would have those sorts of judgments, but or be able to know that they have those judgments in their conscious mind. And so this idea of having people in those positions do unconscious bias training so that they can be more aware of what their biases might be is something that we've done, and we just trained 50 clinicians who would potentially be serving in those roles. So so that's something that I just wanted to pick up on. What, you know,
Tammie, did you train trainees in that, or?
No, these are attendings, nurses. These are people who might serve on a triage type committee as we're pulling together our policies and procedures. And part of our training, our curriculum for people in that position who might be in the process of guiding the resource allocation discussion and making decisions were it to ever come to that, taking the stance that unconscious bias training is required before you're able to be in that leadership role. So
Sushma, to speak to that, we have in our regional boot camp that we do in July for all new trainees that come in critical care medicine, the DC Baltimore quarter, they all go through an unconscious bias training that we implemented this past year, because we think it's so important to our field, especially in general in medicine, but especially our field of medicine.
And to Dina's point, we could have done the implicit association test with age. There's a lot of different pieces there that we could have gone to.
So just to talk about that real quick, and Dr. Curtis, to go back to what you had said, is this did you notice that your teams were sort of making these decisions based on thinking that they were going to run out of resources, and how did you strategize to counteract that, or how did that even come up in discussion?
Yeah, we noticed that our teams, particularly our intensivists, because the same people who were providing ICU care at the bedside were also helping to plan for if we were to hit crisis standards.
Right.
And we just found that people started to say things like, well, you know, this older patient, maybe we should not put them on a ventilator in case ventilators get short, you know, and thinking like that, where, you know, we really never even got close to having a shortage of ventilators in Seattle. So, you know, but it's very easy for that to creep in, and that was why we really wanted to take that on and try to make it explicit and talk about it.
Yeah, that's really important. Well, Nicole, why don't we get back to your talk since we're almost out of time, and I still want to answer a few more questions from the chat.
Okay, so to touch a little bit on end of life, because I think this is what has been hard for a lot of families as well as providers is dealing with end of life, both for patients with COVID and non-COVID as well. So, you know, in terms of just having good visitation protocols for both COVID and non-COVID patients, as I mentioned, all the patients who we were treating at end of life with cancer, heart failure, all of those patients still need our care, but they're affected by the visitation protocols that we have in place to try to protect our patients for COVID, unfortunately. Something that is an interesting conversation that I never had to have before, but now I've had many times, is discussing the potential risk with family members. You know, in our ICUs, we have a policy where at the end of life, one or two family members are able to come in appropriate PPE, but those family members, as we've mentioned before, might be elderly, have other comorbidities of their own, and they need to consider that risk for their family members as well, and offer alternatives to them being there in person. And I found it helpful in having those conversations, is letting them know that there's no right or wrong answer, and it's not a bad decision if they decide they can't be there, and that, you know, we'll support whatever decision is best for them. Because I think there's a lot of guilt associated with that as well for family members who aren't able to come in. And then considering that extubation is a potentially aerosolizing procedure, and normally we you know, do a compassionate extubation with family at bedside at the end of life, but now if family is going to be at bedside, we worry about, again, their risk and exposure. And different hospitals there's many different protocols that I've seen for this, all in some way, you know, keep the ventilator connected on sort of a spontaneous breathing mode, to try to mimic spontaneous breathing as well as we can on the ventilator, while also minimizing discomfort and potential air hunger. And then in terms of symptom management, planning ahead is really key. As you know, it's really hard to go in and out of these rooms. And so when you're sending a nurse in full PPE, you really want to have everything that nurse should be armed with, everything they need for symptom management, especially with family at bedside, because there's just such a delay in getting medications and resources into the room once you're in there. And with that, we'll open it back up to some comments on end of life.
So we've talked about a lot of this. I was also just curious, and I know what we're doing at Emory, but what kind of visitor policy you all had at your institutions, and how, you know, that discussion about giving them information about transmission, and do you have your visitors put on full PPE to come see their loved ones? Do they go in the rooms? How have you all handled that at your institutions?
We have allowed 1 to 2 visitors for patients who are near the end of life. The family members can make a choice. They can see patients through the window, or if they would like, we can gown them up and put them in PPE and they can be in the room. We tend to limit the amount of time they can spend in the room, but we can be flexible on that. I would like to make one quick comment about the extubation issue, because we also have a policy that allows us to leave patients on the ventilator, but I think we don't use it very often. I don't think we should for most patients. And the reason I say that is because while extubation can be aerosolized generating, it generates less aerosol, in my opinion, than a coughing patient. And if we're in PPE, in a negative pressure room, I think that leaving people on the ventilator makes sense if we think their level of support is very high and they're going to die very quickly. But we all have patients who are in the ICU and even get transferred out of the ICU hours, days. And I think in that context, managing a ventilator and the alarms and keeping patients comfortable makes less sense.
Yeah, we definitely haven't been doing that for, if family has chosen not to come or not be in the room. We are extubating, but it's for you, that unique situation when the family members are in the room. But again,
Yeah.
you don't really know how much that's decreasing risk of transmission, if at all.
Yeah, one of the things I developed the protocol for Emory with a work group, and infection prevention, there was a whole piece around the informed consent to the family. And the best part about it, I think, for our process is that we have patient family advisors who help develop a patient family handout or a family handout for that they would be able to go over in advance. One of the things that our patient family advisors were really worried about is making sure that people actually really understood those risks as we talked about, but in a really plain, simple, they actually wrote the handout for us, and I think it's really, really helpful. The piece about the extubation, infection prevention, and I think this is where having different institutions and different infectious disease groups, and as things evolve, that they felt pretty strongly that after extubation that patients there should be an hour after extubation, and this is what they came up with. And so this is, I think, one of the points is that all policies or protocols, and we would call it guidance, not a policy, because I think policy gives you some idea that this is what you have to do. Giving people guidance is a better way of thinking about it. And so deviating from guidance when appropriate, or deviating into what makes sense for a patient. So I think that that at different stages, I think we will be able to do different things as more is known. But early on, I think people didn't know as much. We're knowing more all the time, and I think the ability to revise and update is an important piece.
I just, I want to comment. We here had very similar visitation policies. I think one of the things that Nicole was really great about highlighting was that it's really important to let the families know that either decision that they make is okay, and really supporting them in that. And also, one other consideration with regards to visitation and resource utilization is the burden of visitation on nursing staff, right? This is such a high risk scenario. Visitors really need to be monitored and supervised, and sort of the burden that places on nursing staff. And so in our palliative care unit, we attempted, as best as possible to really sort of standardize specific visiting windows for families, so that we could make sure that nurses had coverage, and sort of really allowing them to do the important work that they were doing.
Yeah, that's a really good point, Dina. I know that when I've brought patients to the ICU, or they've wanted, patient families, and they've wanted to come, I've always made sure that it was a good time for the nurse and that she could be available to get them donned in their PPE. We've had, and it looks like, at least from the chat, visitor policies are very different across the board. I work in our Atlanta VA, and they were pretty adamant about not having visitors. Tammie's aware of that, but I pushed for that because I just felt very strongly that we needed to have family members come by. But some of the pushback I received was actually from the staff and from nursing, not because they didn't want family there, but they felt that we weren't doing just-in-time fit testing. How do we know that their N95 fits them, that we're not putting family members at risk? We have 2 PAPRs for the ICU. Do we give the family member a PAPR? There was a lot of questions and fear surrounding that. I wonder if you all have any comments about that, or thoughts about how we can make everybody feel comfortable in that kind of scenario.
I do think it's really important to understand and respect the stress of staff, nurses, respiratory therapists, physicians, and others. I think underestimating the stress that this places on people is should not, something that can really get you into trouble. So I think that's very important. I also think it's really important that we found early on that there were a lot of these policies that popped up that are not based on any evidence whatsoever. We had a policy that high flow nasal cannula couldn't go above 30 liters per minute for a while. You know, it wasn't, and I think it's really important to sort of say, okay, what is this really based on? Does it make sense? Do we have the evidence behind it? And really try to come together to develop policies and guidance and approaches that really support everybody and that everybody feels bought into.
I think also there's an evolution as more is known, with I think we've just been in a unique situation of not having a clinical trajectory that we could really understand until more recently. And I think that as the evidence has evolved, I bet what we're doing a year from now will look in COVID, because I believe it's still going to be here. I think we all do on this call. I think we may be doing very different things a year from now than we're doing now. And I think that's okay. I don't think it means that we were necessarily wrong, but I think that we will have, the evidence will have evolved. And I think lots of people here on this call are every day working to evolve that evidence, and we need it to be able to make meaningful change and all the things that Nicole's describing.
One of the things that we've struggled with, so we're an institution where there is no visitation in COVID units, even if it's the end of life. And one of the things that we've struggled with is that we believe fundamentally that culture shapes how individuals make meaning out of illness, suffering, and dying. And without having that visitation, we're affecting that culture, I think, a little bit. And so we've struggled with how to bring that culture to the bedside of the patient when the family can't be there to do that. And so whether it's by playing religious music or trying to get some stuff set up in the room, I really liked, Nicole, the baby monitor and the ability to communicate without having to go in. But these are things that we've struggled with by not having patients' families be able to come in at the end of life.
Yeah, I also think this just really highlights how important it is for us to recognize when somebody is nearing the end of life, because now, even if we are line visitors, as you discussed, there's a lot of coordination that needs to happen with nursing and discussing with the family. And so it's really on us. This isn't always possible, but to identify early when we realize that someone is moving in that direction and heading towards the end of life, to give the family time to get there if they decide that's what they want to do.
Nicole, why don't you
Sure.
finish up, since it's already after 9?
Mm-hmm. So in the interest of time, we've talked a lot about safety of patients, staff, and family, and so I won't dwell on that anymore, because I do want to just point out some really great resources that are out there for communication. There's multiple really great resources. Vital Talk, the Center to Advance Palliative Care, Ariadne Labs, all have really great guides on communication. Vital Talk in particular has a COVID-ready communication playbook, which really nicely lays out for different topics, sample responses to what families or patients might say. Everything from advanced care planning in somebody who's not hospitalized yet all the way to the end of life. And I found this very helpful. Vital Talk has an app as well, which is nice. More resources for planning and utilization. Centers who have sort of addressed this, like University of Washington, have sort of published their approach to this in terms of utilization of resources in palliative care. The Center to Advance Palliative Care also has several documents and guidelines that address this as well. And then symptom management is not drastically different in COVID than otherwise, but we have a lot of providers in the ICU taking care of these patients who maybe aren't used to taking care of patients at the end of life. The Center to Advance Palliative Care has some great pocket cards on symptom management, and PalliCovid.app also has a lot of really nice cell phone friendly guides on symptom management, which I found really helpful as well. So with that, I'll open it up to general questions and comments in the interest of time.
So we are a little bit over, but if there are any more burning questions, please put them in the chat. I do want to thank our discussants. It was really such an important topic, and we could probably just keep talking about this. Just one last question before we let everyone go, because I think we all touched on it a little bit, and Tammie mentioned it. I think COVID-19 is going to be with us for some time. We're probably going to see some morbidity, maybe more than mortality from this, emotionally, physically. Have you all given any thoughts on how we can utilize palliative care and our other resources moving forward as we think about sort of post-COVID support, not just for patients, but for families who have been through this? And any thoughts about that at all?
I think we need to remain open to support and what that might look like, because we know that the serious illness trajectory, we actually, if we think about sort of the classic serious illness trajectories, I think that we're not going to know what this one looks like. So I think being able to support, whether it's symptom management, so you can't go through a long ICU stay and being intubated for a long time without potentially not having some pulmonary damage, dyspnea, anxiety, depression, I mean, all sorts of things. So I think that we need to follow these patients longitudinally, and we're seeing a lot of them go to the LTAC environment. And so I think that trying to make sure that we're supporting in those arenas as well, I think is really important longitudinally for some of the sickest patients and seeing what those recoveries are like. But yeah, the physical, spiritual, psychological, social support, us being very proactive and following some of those sickest patients longitudinally and referring them to our clinics and those sorts of things are going to be really important.
One of the things that we formalized in the plan, the EW medicine plan that Nicole showed a slide for, is that palliative care particularly if we got into, well, we did get into contingency, and if we ever got into crisis, palliative care would think of their role as a spectrum from coaching and support to the clinicians doing primary palliative care, sort of brief targeted consults to help with really key issues, to full consults. And I thought that idea of having a spectrum in the way that we provide palliative care support may be something that would be useful even going forward.
It's a great idea.
Yeah, to speak a little bit to that, here at Sinai, we developed a telephonic support 24/7, support system for, non-palliative care clinicians who may need some assistance with brief recommendations for symptom management or even coaching through goals of care conversations.
And that's been published as well.
Yeah. So just published a week and a half ago in New England Journal.
That's great. Thank you for all your hard work in getting those resources out. It's really helpful. And I think it's going to be helpful not just for now, but as we move forward with COVID and with all the other illnesses as well that we're seeing. So, well, it's 9:10, so I will end now. I just want to thank you, Nicole. We're so proud of you at Emory. Thank you for a great presentation.
Thank you for joining.
And for being willing to do this for ATS. Thank you to our amazing discussants, Dr. Curtis, Dr. Khateeb, Dr. Quest. It really was very informative. And if more questions come up, we might reach out to you again from other people. But thank you again. I hope everyone stays safe.
Thank you so much. Take care.
Good night.
Thank you.
Thank you all.